Kia ora tātou, no mai haere mai to our Goodfellow webinar on managing patients after prostate cancer treatment. My name is Katie McCulloch. I'm a nurse practitioner who works for the Goodfellow Unit and in primary healthcare in South Auckland. And tonight we're going to be hearing from Dr. John Tuckey. John is a urologist in Auckland with a special interest in erectile dysfunction, Peyronie's disease, and penile prosthesis surgery. He consults at Ascot Central and has a public appointment at Auckland Hospital. We'll also be hearing from Mr. Giovanni Losco. He's a consultant urologist and paediatric urologist based in Christchurch. He's the clinical director of urology for Canterbury DHB, and he has a special interest in functional urology and cancer survivorship. And just want to say special thanks for supporting this webinar to the Prostate Cancer Foundation and Boston Scientific. I'm now going to hand over to Peter Dickens, who is the CEO of the Prostate Cancer Foundation, as he's going to give a brief overview of what the foundation can do for our patients before our speakers begin. Thanks, Peter.
Thank you. Thank you for that introduction, and kia ora to everybody here. It really is heartening to see how many of you have attended, and on behalf of Boston Scientific and the Prostate Cancer Foundation, we're really grateful for the time that you're taking out to attend. We very much value our relationship with the Goodfellow Unit, and we're grateful for their attention to this important topic tonight. The Prostate Cancer Foundation has been around now for almost 25 years, and in that time we've built up an array of support services to complement the amazing work that you do. We have a network of over 40 support groups around the country, from the far north right down to Invercargill. We provide a range of high quality information resources. We run a busy 0800 information line and an online forum that receives over 400 interactions weekly. While tonight is in large part about life for patients post-treatment, I do have one request to make of you tonight. When a diagnosis of prostate cancer in your patient is confirmed and you receive this news, please take a moment to use the communication tools you have at your disposal to also refer them to the Prostate Cancer Foundation of New Zealand. The journey these men take involves a flood of information and decision-making processes delivered in the context of a health system that is pressured and time poor. Our commitment to you is that we will provide valuable support that complements yours to help your men and their families to pass and process that which they are being asked to comprehend with time, care, and understanding. With that thought in mind, I'm pleased to hand over to Dr. Tuckey so we can commence without further ado. Thank you.
Thanks, Peter. Welcome, everybody. So my topic is erectile restoration after prostate cancer treatment. So what we'll do for a start is talk about how common it is, why does it happen, what restoration options do patients have. There's no one treatment that suits everybody, and so we'll spend a little bit of time talking about two options that you may not have had a lot of exposure to, injectables and implants. And then we'll talk a little bit about penile rehabilitation. Does it work? And if we've got time, we may do some case studies at the end. So what is erectile dysfunction? It's the inability to attain or maintain an erection adequate for sexual intimacy. And as far as erectile dysfunction goes after prostate cancer treatment, when does it happen and how common is it? Well, after radical prostatectomy, it starts straight away. It's very common. It's mainly due to a neural injury, and it reduces over time, so that after 3 or 4 years, some men regain the function of their erections. Around 50% of men develop erectile dysfunction long term. So what about radiotherapy? In contrast to surgery, it develops over months and years. Similar numbers, around 50% long term. And fewer men seem to get erectile dysfunction after brachytherapy. It may be due to the seed placement concentrating the radiotherapy within the prostate itself. Hormonal therapy, it develops over the first month or two. For those on continuous hormonal therapy, 95% of men develop erectile dysfunction, whereas on intermittent therapy, around 50% of those who are sexually active before they start therapy continue to be sexually active afterwards. So the higher brain centers coordinate stimuli from the visual centers, mental centers, and tactile stimuli, coordinated, and then send a signal through the parasympathetic system down to the penile arterioles and cavernosal tissue, causing vasodilatation. And all the treatments we're involved with work on this efferent pathway, either the nerves or the cavernosal tissue. So how does surgery affect erections? Well, the cavernosal nerves lie in this in the fascial planes. You can see my little pointer here. The neurovascular bundle just in the posterolateral aspect of the prostate. And what happens in surgery, the surgeon peels away these fascial layers, try and preserve the neurovascular bundle. But sometimes that's not possible if the tumor is involving the bundle as it is here, or there may be some scar tissue, or maybe just a difficult dissection. Sometimes the nerves are taken with the specimen. If the nerves are able to be spared on one side, it's called a unilateral nerve spare. If they're able to be spared on both sides, it's a bilateral nerve spare. And obviously, the greater the sparing, the greater the likelihood that erections will continue. The other thing to mention about this is that although neural injury is the most common reason why people after radical prostatectomy lose their erections, there is a large amount of veno-occlusive disease. Maybe 70% of people have that too. The emissary veins that drain the blood from the penis have little valves, and if those valves are faulty, blood will leak out of the penis. So even if there's arterial inflow, if the valves are leaky, you never get a really good, strong erection. And so that's quite common in men who have radical prostatectomy or some of these treatments. So what about radiotherapy? It affects erections in a number of different ways. Arterial disease. It also affects the cavernosal nerves and the cavernosal tissue. Hormonal therapy principally works via lowering testosterone, and that's why you have obviously the reduced libido, but it's also important for maintaining the integrity of cavernosal smooth muscle, and it also has a neuroprotective role. As I mentioned before, venous leak is a common issue with men on hormonal therapy, and then you can see from the little icon on the side, it's a bit like a balloon with a hole in it. So why should we be proactive about erectile dysfunction? Well, it's not just about getting erections. It's very important for men's self-esteem and their mood. It also impacts on the relationship that the patient has with their sexual partner and can have a significant impact on their quality of life. Erections, if they are lost after treatment, can sometimes result in penile shortening. The average loss of penile length after radical prostatectomy is 0.5 centimeter in the first year, but 2/3 of men in one study lost between 0.5 centimeter and 5 centimeter in that first year. And that may be able to be prevented. The other reason is that sometimes specialists are very busy and they may be concentrating on other issues, bowel issues, incontinence, and so on. So they may not get around to talking about erectile dysfunction. And so that's where GPs and allied health professionals can come in and play an important role, raising the issue with the patient and then accessing some treatment for them. What about penile rehabilitation? Well, rehabilitation's you're using treatments to increase the chance of the natural erections returning. It's a little bit controversial. It's limited by the quality and duration of some studies, generally small numbers, and the longest study is only out to 12 months. And that's an issue because we've already talked about radical prostatectomy, where the erections can improve for 3 or 4 years. In summary, though, injectables appear to be able to restore erectile function. Vacuum devices and injectables may also be able to prevent loss of length. And in some studies, it looks like early treatment provides a benefit over delayed treatment. So that's one reason why having the discussion early is worthwhile. So in my experience, when men come to see me to talk about erectile dysfunction, it may be that, but it may be something else. I've seen a number of men, when you ask them and drill down, it's actually a low libido. They may have problems with early ejaculation, the inability to ejaculate or reach orgasm, or they may be concerned about low seminal volume. Some men have climacturia as well, which is voiding with an ejaculation. So it's worthwhile just asking the patient what the issue is or what the issues are, because it may be more than one issue. In the history, it's important to ask how the erectile dysfunctions are affecting his relationship with his partner. If the partner is involved in the process, it's much more likely that they'll, if they select the treatment, that they'll stay with it long term. And how is it affecting the patient? What's their self-esteem like? Has it affected their outlook on life? Are they depressed? Because many men can be quite depressed with this, and they may need some treatment for that as well. Now, this is a little bit of a busy slide. You don't need to pay much attention, but just to let you know that when studies are looking at erectile function treatments, they normally use this 5-domain questionnaire to evaluate the effectiveness of that treatment. It's called the International Index of Erectile Function, or IIEF for short. Of the 5 domains, it looks at the confidence that you can keep an erection, how rigid the erections are you able to maintain it, and how satisfied people were with their sexual experience. In terms of the history, it's also worthwhile just noting if the patient is a diabetic or they've had prior erectile dysfunction. These men are often difficult to treat and may not respond to the simple measures and may need to have injectables or an implant. Have they been on any medications that could be linked to prior erectile dysfunction? It's not that uncommon to find men who have started an antihypertensive or something like that, and then they've developed erectile dysfunction. In this setting, though, it's relatively uncommon because there's usually the main antecedent event, which is the surgery, the hormone therapy or radiotherapy. It's worthwhile asking if they tried anything. It's not that uncommon for men to chat amongst themselves and ask their friends, perhaps who have gone through radical prostatectomy or have had the prostate cancer, what sort of issues they've had. Sometimes they even share medications. So it's worthwhile asking if they've tried anything. In terms of examination, look at the hands. Have they got a Dupuytren's contracture, which is associated with Peyronie's disease or scarring in the corporal bodies? Is there any nodularity, any wasting, or any atrophy? Not so much for you, but for me, I always measure their penile length. As we've mentioned before, there can be some shortening over time. And the icon on the bottom right just is to remind everybody there's often a difference between reality and what a man remembers his erection was like, or how long his erection was when he was 16. So is it worthwhile doing a testosterone? Well, in a couple of situations it is. If anyone has symptoms of hypogonadism, it's definitely worthwhile measuring a testosterone. As you can see here, the testosterone has a diurnal variation. The highest testosterone level is around 8 a.m. in the morning. And as an aside, if men are hypogonadal, it's actually safe to replace them. The trigger point for prostate cancer growth is very low in terms of testosterone. And most men we see with a low testosterone at somewhere between 3 and 7, the normal range is 7 to 29 roughly. And the trigger point for prostate cancer growth is much lower than that. So we don't need to be worried that if we were normalizing a man's testosterone, it's going to cause the tumor to grow. Intermittent hormonal therapy, it's worthwhile measuring a testosterone. Then you want to know where they are. The mean time to testosterone recovery is around 10 months. After 2 years, about 70% of men have their testosterone level normalized. But that also means that there's 30% of men who still don't have a normal testosterone 2 years after stopping treatment. Interestingly, a small number of men, between 1 and 3%, have no erectile difficulty at all on hormone therapy. We don't know why that is, but some men don't need any support at all. So in terms of treatment, what's the issue? Is it an associated low testosterone? As I mentioned, normalization is acceptable. Climacturia, avoid before intercourse and try a condom. If it's low seminal volume, it's worth educating patients that it's normal that the volume actually decreases with age. With radiotherapy, it becomes very small. And obviously with a radical prostatectomy where the seminal vesicles are removed, there's no fluid at all. Some men after radical prostatectomy have pain with ejaculation. It may improve with time, but it's actually quite difficult to treat, but it may improve with time. And one thing that men don't normally know is that they can orgasm or climax with a flaccid penis. They don't need an erection to be able to have an orgasm. So what about treatment options? Well, there are a number of herbal options. Horny goatweed's found in something called Herbal Ignite. It has PDE5 effects, although it's much less potent than Viagra. Ginseng and arginine both also work on the nitric oxide pathway. You may have heard about low-intensity shockwave lithotripsy. This is used in musculoskeletal disorders and has a good reputation, but it doesn't have that reputation in erectile dysfunction. It's been tried on a number of occasions, good studies, and they're generally negative. The mechanism of action is unknown. You get a small change in the IIF score of maybe 2 to 3 out of 25. But interestingly, in most studies, if you actually have a placebo arm, the change in the IIF score is around about 4. So the shockwave lithotripsy change is not clinically significant. So what about PDE5 inhibitors? These are the first option for most people. Now, I've put in a biochemical slide. It wouldn't be a proper talk without one little biochemical slide. The reason for this is twofold. Firstly, it explains what we observe with men having sildenafil, and it also explains why men with a radical prostatectomy don't normally respond to sildenafil. The sildenafil pathway is you have a nerve here, releases some nitric oxide, and then it goes through this cyclic GMP pathway and results in arterial smooth muscle relaxation and then an erection. So with radical prostatectomy, if the nerves are damaged, they won't be able to respond to sildenafil. They need some nerves or some neural function. The other thing is that sildenafil works on the off switch here. This is the off switch. So essentially, it potentiates the natural pathway. So that's why men who have sildenafil end up with an erection that's slightly more rigid than you'd expect and longer lasting. PDE5 inhibitors are most effective in radiotherapy. Up to 70% of men respond. It's a little less with hormonal therapy, and surgery, it's generally around 20 to 30% of men respond. So which agent is actually best? It mainly depends on personal preference. No PDE5 inhibitor seems to be superior to another. Daily dose Cialis, 5 milligrams a day, is popular because it allows spontaneity back in the relationship. They've always got Cialis in the system. They can have intercourse whenever they want. The issue with it is it's quite expensive, around $250 a month. So for most men, choice is based on a combination of things. It may be cost, how often they want to have intercourse. So if they only want to have intercourse once or twice a week, it may be better to use on-demand sildenafil or Cialis. And it's also based on side effects. Sometimes you have a side effect with one and not with another, and that's another reason why it's worthwhile trying both treatments. So what if a PDE5 inhibitor doesn't work? What sort of questions might you ask? Well, have they tried a full dose? Are they waiting 30 minutes? Are they using stimulation? Some men think that it will give them an erection, but you have to have stimulation. Are they taking sildenafil with fatty food? It delays the absorption. And have they tried the other PDE5 inhibitors? Because occasionally you may respond more to one other than another. What about PDE5 inhibitors and penile rehabilitation? Well, in surgery and radiotherapy, while you're taking the PDE5 inhibitors, it may produce an erection, but it doesn't seem to improve the chance of your natural erections returning, although the caveats are the studies are only up to 12 months and recovery can take 3 to 4 years, as we know with surgery. So what about vacuum erection devices? They consist of a perspex cylinder we have here, some way of generating a vacuum, in this case a battery operated pump, but it may be manual, and then some lubricant to promote the seal with the pubic bone. And that's all you need for penile rehabilitation. But if you're looking at using a vacuum erection device for erections, you need some of these constriction rings at the base. So this is how it works. Lubricant's placed around the base of the perspex cylinder. It's also placed around the base of the penis. It's helpful for the patient to shave so that it improves the suction effect. Then suction is applied and erection is produced, and that's all you need for penile rehabilitation. But if you're looking at having an erection for intercourse, then the little gray constriction ring at the bottom here, there, has slipped onto the base of the penis. The vacuum erection devices increase tissue oxygenation. It's not just venous blood they draw into the penis. There's some arterial blood, and the oxygen capacity increases in the corpora by around 50%. Vacuum erection devices are thought to reduce penile shortening. In terms of a change to IAEF scores, it's only about 4, which is what we would see with a placebo. So it's probably of no clinical significance. And what about rehab? How often should you use it? Well, a lot of rehab studies would suggest something like 5 minutes a day, so 5 minutes twice a day. If you're using a vacuum erection device for intercourse, it's recommended that you leave the constriction ring only for about 30 minutes because the cavernosal tissue becomes quite hypoxic after that time period. So with the vacuum erection device, are there any downsides? Well, some dexterity is required. Some people say it can be a bit clunky and interrupt the moment. There is also a hinge effect. This diagram on the right-hand side, you can see this is a penis. This is a penile implant within a corpora, but you can see the corpora extends underneath the pubic bone here. So when the constriction ring is placed in this region, from the constriction ring to the glands is rigid, but from here proximally is flaccid. So you can end up with a hinge effect. The devices are relatively inexpensive, around $600, and they last for quite a few years. So that can be quite an economical way of treating erectile dysfunction. So if those devices don't work or don't appeal to tablets or vacuum erection device, well, intracavernosal injections are another option, and they're stronger than both of those options. There's three main agents: prostaglandin E1 or alprostadil, papaverine, and regitine, or a combination bimix, which is papaverine and regitine, or all three is called trimix. Prostaglandin E1 is the most commonly used one. It has the lowest risk of priapism, so that's the first one to try in my book. It relaxes the corporal smooth muscle as well as dilating cavernosal arteries. There's some theoretical risk it may reduce fibrosis via TGF-beta. And obviously with the arterial blood flow coming in, that nourishes the corporal tissues. And as I mentioned, you get a stronger erection than with PDE5 inhibitors or vacuum devices. It's probably useful in rehabilitation. There was one study that found you had an increased chance of spontaneous erections. If you used 3 injections a week for 12 weeks, and then they reassessed the patients at 6 months, 67% of those in the treatment arm had return of the spontaneous erections, excuse me, versus only 20% in the control group. Starting early also appeared to improve matters in one study. If you start early at 2 months, you get a better result than at 7 months. Now, patients never find it appealing, but once they've had an injection, they are usually surprised how easy it was and how little discomfort. The little needle we use is 29 gauge. You can see on the diagram on the right-hand side, this is an axial image of the penis. We get them to inject at, say, 10 o'clock or 2 o'clock if you think of it as a clock face. I start with a low dose alprostadil, as some men are quite sensitive to it, somewhere between 2 and 5 micrograms. The erections are produced in a few minutes. You don't normally need stimulation. And then we get the patients to titrate the dose up until they find an erection that's as rigid as they want to do and has the duration that they're looking for. So PGE1 is available from compounding pharmacies. There is a commercial preparation called Cavaject. It's more expensive, but the advantage of that is that it's in powder form, so it doesn't need to be kept in the fridge as the liquid forms from the compounding pharmacies are. Another nice feature is, as you can see on the diagram here, there's a little window on the side of the needle, which you can dial up the dose that you want. So that's good for and easy for patients to use. Some men are anxious, even with practice, and auto injectors can be helpful. They place the needle within the corpora and then the patient just has to push the plunger to inject the fluid. Occasionally, men with a radical prostatectomy can get pain with a prostaglandin E1, and they may need to use another agent like Bimix. Sometimes there can be some scarring. It's uncommon, but it has been reported. Some of the issues with complications from prostaglandins are related to patients using too high a dose or maybe double dosing, because tablets and injectables sometimes don't work. They may be injecting in the wrong place or not too superficial or too deep, and so it doesn't work. So always worthwhile mentioning to the patients, if it doesn't work, don't bother trying another dose, because they may end up with a priapism. A priapism is an erection that lasts for more than 4 hours. If they get to the 4-hour mark, we ask them to have a cold shower and take something like phenylephrine or pseudoephedrine. And if that doesn't work, they need to go up to Auckland Hospital or wherever the local hospital is for corporal drainage and placement of an alpha agonist in the corpora. Drawbacks, as we mentioned, it may affect spontaneity, interrupting the moment. Occasionally they're not effective, and as I said before, they need to be kept in the fridge. Most injections last for between 3 and 6 months, so there's a reasonable longevity there. The other issue is that if you're going on holiday or traveling, you always need to remember to take them with you, which is the same with tablets, but not the same with penile prostheses. So we'll talk a little bit about penile prostheses. You may not have been aware of them or had any exposure to them before, but penile prostheses have the highest satisfaction rates of any treatment, and that's because they solve the issues with the tablets. They're more reliable, they work every time, and they allow the spontaneity back into the relationship. They're quick to inflate or quick to use. They've been around for a long time, over 30 years. Worldwide, over 25,000 implants are performed a year, and there's been over 300,000 implants to date. They have a lifetime warranty, and so if there's ever a failure, the company will replace them for free. Now, what are the advantages? We've mentioned some already, but they produce a very rigid, natural-looking erection. And the other thing is, for men, they can have erection as long as they want. It's not they don't need to be worried that the erection is going to fade before they're finished. It takes just a few seconds to inflate, probably 30 to 60 seconds. And because of that, it can be inflated during foreplay. And so the spontaneity can return to the relationship. They work every time. And the fact that they may not work, tablets or injectables, can produce performance anxiety, which can be a major issue for men. And because men know that that's going to work, it restores their self-esteem. And it's quite common for men to be anxious, withdrawn with erectile dysfunction, and this just transforms their life. As I mentioned, you always have it with you, and there are no ongoing costs. It's just a one-off payment. So there's two types of malleable prosthesis on the left and the inflatable. We'll talk briefly about both. The malleable prosthesis fits within the corpora. It's measured for each individual patient so they have the correct fit. That this sort of transparent or lucent area at the end contains some metal wiring, but basically when you bend it, it stays in that position. So you can bend it down to simulate a flaccid penis or bend it up when you want to have intercourse. They're easy to use, good if there's a dexterity problem. They're very reliable, and they're the least expensive of the options. The inflatable prosthesis is the Rolls Royce. It's a simple hydraulic device. There's fluid in a reservoir, a pump, and cylinders. You can see the reservoir is here in the pelvis, or sometimes it's underneath the transversus abdominis. The pump is placed between the testicles, and the cylinders are within the corpora. And when a man wants to get an erection, he just compresses the pump and fluid is transferred through here to the cylinders. Here's an animation which basically explains what's happening. So when a man wants an erection, he grabs the pump, which is in the dependent portion of his scrotum between the testicles, and fluid is transferred from the reservoir through the pump to the cylinders. And when man's finished, he pushes the single return valve and fluid transfers back through the pump to the reservoir. So it's a very simple system. This is the Boston AMS 700, which is the most popular implant. And this one is popular because it expands in length. All implants expand in girth, well, all inflatable ones expand in girth, but this is the only one to expand in length. It's got a special yellow inhibisone coating to minimize the chance of infection, combination of rifampicin and minocycline. And you can see in this agar slide down the bottom that it does prevent bacterial growth. Now, the satisfaction rates are higher for this than any other treatment option. And for the patient and the partner, in terms of the erection quality, the satisfaction rates were somewhere between 83 and 98%. And in terms of sexual activity, it's between 92 and 98%, so very high. So who's suitable for an implant? Well, men who fail or dislike other treatments. If men can't use injectables because they hate needles, or the other treatments are ineffective, and it's usually mostly because the other treatments are ineffective. It's important to wait for at least 12 months after surgery to see if there's any recovery of function, and it's fully funded by insurers, which is good for patients. It's important to set expectations beforehand. The penile length is slightly reduced due to the glands not engorging, and it's slightly colder because of that. Stretch penile length is an accurate, or correlates very accurately with the length of an erection. So it's important to measure that and make sure that the man understands what the size of his penis will be after surgery. And complications are uncommon. Infection is very rare these days, and mechanical failure as well. What's involved? Well, essentially, it's a one-night stay in hospital, 2 weeks recovery time, and then we get the patient to inflate them 4 weeks later. So in summary, GPs play an important role in having the discussion, or allied health professionals as well, and having that discussion, define what the issues are, encourage them to start early, explain the full range of options, use the options that you're comfortable with. And if there are other options that they're interested in, but you don't use yourself, we'll refer them on to someone who is familiar with them. And what about penile rehabilitation? Well, the optimal penile rehabilitation protocol isn't really known. PDE5 inhibitors do not appear to aid the return of natural erections. Vacuum erection devices are effective at preventing shortening, and injections seem to prevent shortening as well as the return of natural erections. So a combination of the vacuum erection device and injectables is probably the best option for rehabilitation. And in terms of prostheses, they have the highest satisfaction rates. They've been used for 30 years. They're very durable, and they solve the issues that men are worried about: the performance anxiety issue, the spontaneity issue. They're quick to inflate, and the patient always has them with them. And it's very common to find men who've had implants that's made significant improvements to their self-esteem. Alrighty, so we're at 30 minutes nearly, Katie, I think. Should we do a case, or should we just leave it and then move on to Giovanni?
I think if we move on to Giovanni, and we can see if we've got enough time for a case at the end.
Okay, sounds good.
Hello, everybody. Thank you, John. So I'm going to talk about incontinence, which is the other major survivorship issue for men that have treatment for prostate cancer. A lot of the etiology and pathogenesis is very similar, and the concepts are the same. Incontinence tends to be the first issue that men really struggle with, and once they can get on top of that, the erections tend to be the second issue. So we talk about this as post-prostatectomy incontinence because mainly it's for men that have had their prostate removed. So broadly, some goals for tonight. We'll talk about how common it is, why it happens, risk factors, so why some men seem to be more affected than others, and then importantly, some of the different treatment options which are available throughout New Zealand. And then briefly, I'm going to touch on the ACC process because that's a really important thing to get your head around, particularly in primary care, to get men the access for this treatment. So after a radical prostatectomy, which is complete surgical removal of the prostate, whether it's done with an open incision or via a robotic approach, everybody is expected to be incontinent. So leakage of urine is expected immediately after surgery once the catheter is removed. Catheters usually in for 1 or 2 weeks, but we'd expect most men would be wet to some degree. But that rapidly improves. So by 3 months, a third to half of men will still be wet. By 6 months, we're talking 10 to 20%, or 1 or 2 men out of 10. And then by a year after surgery, less than 5% of men, or less than 1 in 20, will still have significant incontinence. Now, it depends a little bit around how we frame that. A lot of the studies that have been done would say that 1 pad a day is considered to be dry. That's not really dry for everybody, but a lot of the studies frame it like that. So certainly using 2 or more pads a day at 1 year after surgery would be very uncommon. And this is really the group of men that we're thinking about tonight, the men that we can offer some other treatments to try and get them dry. So, very briefly, the anatomy. When I first started in urology as a registrar, it really struck me that the prostate was not an organ that was designed to be removed. It's really buried deeply in the pelvis. It is connected very densely to the urethra by some ligaments down here, and really forms the lower part of the bladder. So the open radical prostatectomy was really a revolution when about 30 years ago, they finally figured out how to remove this organ. What that means, though, is that it's close to a lot of really important structures, and particularly the sphincter. I think you can see my cursor on the screen is immediately and intimately related to the base of the prostate. And the sphincter necessarily gets a little bit damaged or injured at the time of surgery. This schematic tries to demonstrate what actually happens or the physiology in the pelvis. So you've got the bladder here, urethra running out through the end of the penis. The sphincter sits really, really close to the prostate, and the prostate is also really fixed inside the pelvis, and it acts as a really strong support to the bladder. Once the prostate's removed, you can see in the second picture over here that suddenly one of those really key supports in the pelvis is gone. When the patient valsalvas, your typical coughing, laughing, sneezing, all of that intra-abdominal pressure is then forced on the sphincter alone. There is no longer any other support. So that prostate is a really key support, which is gone. And then the sphincter, which has been super close to the prostate at the time of surgery, that sphincter has been given a bit of a shock, and in some cases a little bit more than a shock, a bit of damage. So you can see suddenly why incontinence after prostate removal is a lot more common. In women, as we all know, stress incontinence is far more common a problem than in men for a variety of reasons, but this is one of them. Women have got less support inside the pelvis. There is no prostate to add that additional dimension. So women are far more prone to stress incontinence, and the same reason that men without a prostate are more prone to it. Incontinence comes in different shapes and forms. And this isn't really a talk designed to walk you through all the different types of incontinence, but the type of incontinence that we're really thinking about after prostate surgery is stress incontinence. So that's the poor support of the bladder by the sphincter and by the pelvic floor, coughing, laughing, sneezing. Urge incontinence, or an overactive bladder, is another type of incontinence, which is slightly more common in men that have had radiation treatment. So that's the not being able to hold on, key in the door, rushing to the toilet, that kind of thing. So bladders which don't relax properly, but they're sort of squeezing away like this. So that causes urge incontinence, which is a different problem. And none of the things I'm going to talk about in the next slides are related to urge incontinence. Urge incontinence is normally managed with medical therapy, drugs like solifenacin. It's actually the only drug we have in New Zealand with the recent loss of oxybutynin to manage urge incontinence. The degree of cancer will affect the degree of incontinence. If you look here in this picture, when the surgeon is undertaking a radical prostatectomy, if they've got this cancer here, a T3 cancer, which is actually invading the outside of the prostate, running very close to the sphincter here. Obviously, the surgery number one aim is to cure the cancer. So in an effort to actually remove all of the cancer, the surgeon's going to get very, very close to the apex of the prostate and near the sphincter to make sure the cancer is adequately removed. But that's more likely to cause a little bit of injury to the sphincter than a cancer which we know is actually well and truly inside the prostate. We're not quite as fussed about getting very, very close to the sphincter. So degree of cancer is one reason why incontinence can be more or less after an operation. There's also patient factors. So men who are overweight have a more challenging anatomy. So I said the prostate's down a deep, dark hole that wasn't really designed to be removed. So if the body habitus is such that it's going to be more difficult to access that area, there's going to be a higher chance of sphincter damage. Men that have had radiation as well as surgery, typically it happens afterwards, as salvage radiation, are certainly at higher risk, because in those men, the sphincter's really had two insults, the first being the surgery, and then the second insult to the sphincter is the radiation on top. Very small group of men will have it the other way around. They will have radiation first and then surgery later. That's particularly challenging surgery. And in those men, incontinence really is an expected outcome due to the difficulty of the operation. So there's a few things we do when in the workup of these men. Obviously a standard history and examination, particularly trying to check that this really is stress incontinence that we're dealing with here, coughing, laughing, sneezing, rather than the urgency, because that's immediately going to divide us down a different pathway if we're dealing with someone with an overactive bladder. A basic physical examination to check that the bladder is emptying properly. We're not dealing with an issue with a scarring of the urethra called a bladder neck contracture where the prostate's removed, things block up, the bladder may be very, very full, i.e. the patient's in retention, and those men might have an overflow incontinence problem. So that's a simple thing to assess on physical examination. So aside from your history and then physical examination, then you're going to look at some simple treatment, which we'll come to shortly along the lines of pelvic floor muscle exercises. There's one other thing I think I wanted to point out, and maybe I deleted the slide, but just going back here, is to point out that the nerves that supply the prostate that supply the sphincter and also the erections run extremely close to the prostate. So right on the capsule here, right on the side of the prostate is where the nerves are. And sometimes the surgeon will deliberately try and spare the nerves, if that's going to be okay in terms of treating the cancer. Sometimes the surgeon will deliberately actually resect the nerves or take the nerves. And in those cases, there's going to be a higher risk of trouble with incontinence because those nerves have actually been removed. So yeah, getting back to our investigation pathway, these are the sorts of tests that may be done in a urology setting once the patient has typically failed conservative management, which would be the pelvic floor muscle exercises. We can do a test called urodynamics, which is an invasive test of bladder function. It's not particularly glamorous, I have to say. It involves putting a little tube into the bladder. This is actually a female pelvis for those of you who are still awake, so apologies for that. Just a trick, but this is a little tube going into the bladder and a little tube, in this case going into the vagina, sometimes placed into the rectum. And this measures the pressure inside the bladder. It comes up with some tracings that tell us how the bladder is behaving. We would typically get the patient to cough to see whether that elicits the incontinence and would confirm the presence of stress incontinence. The other thing we often do is a cystoscopy, which is a telescope looking in to the bladder to check for that scar tissue problem I mentioned earlier, the bladder neck contracture. Really important to make sure someone doesn't have a blockage or obstruction problem if you're going to go on and treat an incontinence problem. So how do we fix it? We'll talk about some of the treatment options. The mainstay of treatment for all men that have prostate surgery is pelvic floor muscle exercises. We typically educate men in Christchurch preoperatively. They all go to a session where they're told of the importance of pelvic floor exercises. And there is evidence in what we call prehab rather than rehab. So actually strengthening your pelvic floor muscles before surgery has been shown to improve your return of continence after surgery. So pelvic floor muscle exercise is really, really important. And certainly after surgery is very important. The sooner you do them and the more diligent the patient is with doing those pelvic floor exercises, the sooner the return of incontinence. What we do know about pelvic floor muscle exercises is it isn't going to change the ultimate level of continence. So what I'm trying to say there is, if a man is always destined to ultimately end up, somewhat wet, the pelvic floor exercises won't make him completely dry. They'll just get him to that point, their sort of peak continence status more quickly. And in fact, I've had an example recently of a man who unfortunately was very diligent with his pelvic floor muscle exercises, but was completely doing the wrong thing. I'm sure you've all seen patients that don't really understand where their pelvic floor is, and when they try and do an exercise, they're sort of hunching their shoulders like this, and they're just not squeezing the right muscles. And I discovered actually that 9 months down the track, he was doing quite the wrong exercises, and he was still very wet and very upset about it. And I sent him along to a specialist pelvic floor physiotherapist. She taught him to do exactly the right things, and actually he was completely dry within 3 months. So it actually just goes to show that it's never too late to start the pelvic floor exercises. And they're really the key way to try and get to full continence if you can. But unfortunately, for some men, which is why we're here tonight, they can't always achieve full continence. Broadly speaking, there's 3 options available in terms of surgical management of continence in New Zealand for men. There's been a few other devices come and go, both locally and internationally over the years, maybe other things you've seen older patients with. But I'm going to talk tonight about the advanced sling, the Atoms sling, and then the artificial urinary sphincter. So the advanced sling has been around for 15 or so years. It's a simple piece of mesh with no moving parts, which is placed through the transobturator fossa on each side and sits under the urethra, supporting the urethra like a hammock. I often explain to men that it is a little bit like a hammock just sitting under the urethra. The broad part of the sling is this wider area here, and then there's two arms, the left arm and the right arm, that go up through the transobturator fossa. They have some barbs on them, which are these slightly mean or gruesome things looking here, which really hold it in place. These slings actually work to a degree by obstruction. So they actually cause a degree of obstruction of the urethra. Most men after a sling will find that their flow lessens. It's not as strong as it used to be. There is a slightly higher risk of urinary retention after this operation. But you've got to remember that most men are used to managing with a degree of outlet obstruction. Most men grow old with BPH, and in fact, this group have had their prostate surgically removed. So the presence of that obstruction doesn't seem to be a long-term issue for this group of patients. So it's a relatively simple operation, one night in hospital. It's done through an incision in the perineum, so incision behind the scrotum in the lithotomy position, catheter in overnight, home the following day. It works really well for men with a more mild degree of leakage. So men who have very severe leakage tend not to respond as well to this. You might say, well, how do you grade the degree of leakage? I do a thing called a 24-hour pad weigh test, and that's pretty much just what it sounds like. I get them to go home, weigh their incontinence pads, all the pads that they may have used for a 24-hour period, just on their kitchen scales, subtract the weight of the pad when it's dry, then you'll get a number. Anything above 400 grams, which equates to 400 mils of urine a day, is considered severe. Less than 100 is sort of mild, and in between is the sort of moderate range. So the advanced sling works well for men with mild incontinence and reasonably well for men with mild to moderate incontinence, but not so much for men with severe incontinence. It does depend on what they want to achieve. If they want to be completely dry in every situation, basically nothing can guarantee them that. But if that's what they're looking for, this will be not such a good option. If they want a really simple option, compared to what I'm about to show you in the next few slides, this would be a more suitable option for them. This is the advanced sling. I'm not sure if anyone's thinking about mesh, because there's been a lot of coverage about mesh over the last few years in the media. Really interestingly, there have been almost no reports of adverse effects of mesh in men. We have a few ideas why that may be, but we don't fully understand it. The anatomy is very different, but the short answer is this mesh is considered to be very safe. And there's been really no issues around it internationally. So this is the advanced sling. The second sling is the atom sling. Now they've kind of borrowed the concept of the advanced sling in that it's placed in exactly the same way, sort of a hammock that sits under the urethra, comes out through the transobturator fossas. But now, instead of that simple little bed of mesh sitting underneath the urethra, there's a cushion made of silicone, and that cushion can be filled with saline. And that cushion filled with saline provides some compression of the urethra to reduce the leakage. The other smart little thing about this is that cushion is attached to a little port that sits here in the scrotum that you can actually top up with extra fluid. So it's all internalized, but once the man's recovered from his surgery, he can come and see the urologist in the rooms, and a little needle can be passed in through that port to increase the amount of fluid inside the device. So that's what the cushion looks like when it's filled with fluid. It's got those mesh arms running through the transobturator fossa. And this is the slightly gnarly looking trocar that we use at the time of surgery to actually pass it through the transobturator fossa. Very similar post-operative course to the advanced sling. These men do tend to be a little bit more sore. If they really do a lot of cycling, really the sort of road cyclists out there, possibly not as well suited to them because they are sitting directly on this cushion and it can be sore. The gold standard is the artificial urinary sphincter. And the reason I call it the gold standard is it's been around a long time. It's been around in excess of 30 years. It's had a few modifications along the way. It's made by exactly the same company that makes the penile prosthesis that John showed you in his earlier talk. There are other companies that also have made similar devices, but the original device is this one called the AMS 800. The penile prosthesis device is called the AMS 700. But there's three parts to it. There's a cuff which sits around the urethra, completely encircling it and closing it off. There's a reservoir, little balloon of fluid which is buried inside the abdomen. And then there's a pump or a button that sits inside the scrotum. And much like the penile prosthesis, when the man wants to void or go to the toilet, he'll pump that pump. That will have the effect of opening the cuff, which allows them to pass urine. Then that cuff will automatically close over the next minute or two. Again, this is what it looks like. You've got this is the cuff when it's been rolled out. That's how it comes out of the packet. We then put it around the urethra. This is the balloon when it's, again, out of the packet. It's deflated. It's not currently filled with fluid, and that's the pump. And just like that penile prosthesis, it's also impregnated with an antibiotic called rifampicin, which is what gives it this, this orange color. This is a very successful device in terms of continence rates. The downside is it is a little bit more fiddly. And there are a few men either with dexterity issues due to arthritis or sometimes with cognitive dysfunction that do struggle a little bit just to use this and also to remember to use this. Inside the body, the components are all connected. It's done with 2 incisions, same incision behind the scrotum in the perineum, and another incision. So there's 2 incisions for this operation in the lower part of the abdomen to place this reservoir. Typically one night in hospital, catheter in overnight, home the following day. This device is switched off, so the man will continue to leak for the first 6 weeks. They'll still be incontinent. At that point, they'll come and see the urologist who will switch it on. And at that point, you would hope that they would now be dry. Not everything's perfect. And one of the great fears we have of the artificial sphincter is it can actually erode. What this picture is trying to show you, this is a cystoscope looking in through the urethra, so through the penis. And what we're actually faced with here is a whole lot of plastic sitting inside the urethral lumen. So clearly not a normal situation. This is a complication. And the problem with these complications is that they all result in the entire device needing to be removed or explanted. This is demonstrating, again, that same view. Perhaps I should have showed this picture first. It might have been easier to understand, but this is showing you that view of the urethra with the cuff closing the urethra. In this particular example, the cuff is in a partially closed situation, so it's not completely occluding the urethra, but you can see clearly how it's really decreasing the urethral lumen and the urine is going to pass through that passage. Effective rates or effectiveness are actually similar for all 3 devices if you have appropriate patient selection. We said the advanced works well on the more mild patients. Artificial urinary sphincter works well for all of them, but particularly in the severe group of incontinence. The ATOMS also works reasonably well across all 3 groups. I typically tell people about a 90% chance of being dry. This is some American data where they talk about a 75% chance of being dry. I have to say that's not been the New Zealand experience. We tend to see higher dry rates than that. About a 95% chance of being significantly better, but maybe not being completely dry in every situation. And I say to guys that are having this operation, if you're doing really heavy work, like, wood chopping, that kind of thing, there's really nothing we can do in terms of surgery that is going to guarantee dryness in every possible situation, because wood chopping involves a huge intra-abdominal pressure or Valsalva. It's a mechanical device, so like your car, it's prone to breakdowns. If it has a breakdown, it needs a service, and if it needs a service, that means another operation. So having a device like an artificial urinary sphincter or the penile prosthesis in your body isn't without problems. there's about a 25% chance in a 10-year period of needing a revision operation, either to replace part or all of the device. Things that can go wrong would be fluid leaking out of the system, something becoming disconnected, erosion of the device, or the worst case scenario is infection. If the device is infected, the whole thing typically has to be removed. Can be replaced at a later date. So the final thing I wanted to cover off in the last few minutes is funding, because this is really, really key. ACC, treatment injury, people will be familiar with. There's many quirks of the healthcare system in New Zealand, and one of them is that incontinence after radical prostatectomy or prostate cancer removal is considered to be a treatment injury because it's caused by urethral sphincter injury. Because of this, DHBs don't fund it because, reasonably from their perspective, these patients have an alternative funding pathway, which is ACC. So anybody can start that treatment injury claim process. It can be done in primary care, it can be done in secondary care, it doesn't matter. The surgeon who undertook the surgery doesn't need to be informed. There's no requirement for their involvement or consent. It's a no blame process. So by putting in a treatment injury doesn't mean to say you're pointing the finger and saying, you did a bad job. It's really about accessing the appropriate funding to allow the patient's care to move forward. Typically, they need to have a reasonable degree of incontinence. So I've said here 3 pads per day. It's probably not quite true, but if they're using 1 pad or less a day, it may be a little bit harder to convince ACC that this is not an ordinary consequence of surgery. It takes them about a month or so. Sometimes it can take up to 2 months for them to actually make the decision. But once they've made the decision to approve the ACC claim, the workup for treatment can actually commence. There's a couple of really important things I want to say about writing the ACC treatment injury claim. You probably know that the legislation is all around a physical injury. So we have to prove there's been, or we have to say there's been a physical injury. Incontinence is not an injury. Incontinence is a symptom. If you write that down, it'll just be declined. The buzzword is to say that there's been a urethral sphincter injury. If you say that, you don't necessarily need to prove it. But if you say that that's the physical injury, you're immediately going to really increase the chances of this person's claim being approved straight up, particularly without ACC going back and asking for other opinions and asking for other tests to be done. The other thing I wanted to say is that the legislation here is very grey. Originally, or the current law says that the outcome needs to be not an ordinary consequence of an operation. That was recently challenged in the High Court and then appealed to the Supreme Court. And the Supreme Court judges have come up with an even more grey definition, which is to say that the outcome needs to be surprising. So if the outcome of surgery is surprising, then that would constitute a treatment injury, and incontinence is considered to be surprising, so therefore it constitutes a treatment injury. Erectile dysfunction, unfortunately, is not considered to be surprising, so most of those men don't unfortunately get treatment injury claims approved, such as the legislation that we work within. ACC funding is not just about the surgery, of course. It gives men access to a lot of other things, including their care, 80% of their income lost for their time having surgery and recovering from maybe their sling procedure, the cost of all their pads, incontinence products, the cost of their traveling to and from hospital, and should there be any further complications down the track, it will cover them for that. So it's really advantageous to have this claim behind them. I think I've covered this actually, urethral sphincter, that's the really key take-home message from my talk tonight, possibly, is that's the thing to write on the ACC treatment injury claim. If they've had radiation as well, ACC sometimes, will say, well, this makes it less surprising, so therefore we're not going to approve it. Clearly, if they already had incontinence before their surgery, it's going to be harder to say this is because of the surgery. I'm not going to dwell on the case, or I'm not going to talk about the case actually, because I think we've we've sort of run out of time. So I'll hand back to Katie, and I think we're going to have an opportunity to have some questions.
Thank you, Giovanni and John, for giving that very good overview of both. I'm sorry that we didn't have enough time for the case studies, but we do have some questions, so we'll see how we get on with those, and we can go back to the case studies if we have time. There was a question that came through, John, while you were speaking, just about the difference between radical prostatectomy and robotic, whether open radical or robotic was better.
In terms of erectile dysfunction, I think it really depends on the skill of the operator and their experience. So I don't think the most important thing is the modality used. I think it's the skill of the surgeon.
Okay. In terms of removal of devices, so we've got a person here who's got a patient who's got mild dementia and has the artificial sphincter and has forgotten how to use it. Is it possible to remove it, Giovanni?
It's certainly possible to remove it. Removing the devices is actually, it's an operation, but it is relatively straightforward.
Okay. Will ACC cover for urethral sphincter injury if the prostatectomy was done overseas and more than a year ago?
Yeah, that's a really good question. So timeframes are relevant. So it doesn't matter when it was done, so long as it was before 1974 or whenever ACC came in. Where the patient lives is important. So if you are living in New Zealand, but say travel to Australia on holiday and have your surgery done there, ACC will fund it. But if you are actually living outside of New Zealand when you have the surgery, it won't be funded.
Okay.
John, do I have that right? I think that's correct.
It sounds about right.
Yeah.
Cool. What are the costs? So what's the cost of the Boston device and the cost of hospitalization overnight?
The Boston device is around about $17,000 to $19,000, so it's reasonably expensive. All up the surgery probably costs somewhere around $30,000 to $35,000. But as I mentioned, it's funded by the insurers. It's just if someone wanted to self-pay, that's the sort of figure they'd be looking at.
Right. And is this only funded after a radical prostatectomy, or can it be funded after radiotherapy as well?
There's no limits on it. It's for vascular disease, diabetics, radical prostatectomy, radiotherapy, whoever, as long as they don't have an exclusion in their policy.
Okay. Is there any, what are the chances of getting an erection after 5 years post-op after a radical prostatectomy, when there was little support investigating options originally after the surgery? Apparently the patient has tried a pump and Viagra with minimal success.
Well, the chance of natural erections returning after 5 years is very low. It's normally 3 to 4 years. I'm not sure with you, Giovanni, but the longest I've had is about 3 years. But 5 years, it's still fine, you know, with injectables. It depends on how much damage, but as occurred with radical prostatectomy in terms of venous leak and so on. But it's certainly possible because injectables bypass that route.
Okay. And how would you manage erectile dysfunction with patients that have BHP taking doxazosin to increase the urine flow?
Well, the Rolls-Royce treatment would be to give them daily dose Cialis, as Cialis is registered and approved for use in BPH, as well as erectile dysfunction. But as I mentioned, it's quite expensive. So I think offer them daily dose Cialis, but if that wasn't an option, well, then we'd look at using adjunct, the standard sort of adjuncts like sildenafil or injectables.
Okay. Is mirabegron available, I'm sorry if I've said that wrong, in New Zealand for patients not responding to sildenafil? So I'm sorry. Say that one.
I can answer that. Look, it's not currently funded, but the Urological Society in New Zealand have really been campaigning hard with Pharmac to get that funded, because the fact that we're left with a single drug now to manage overactive bladder really isn't acceptable, particularly when the Australians have had mirabegron for 10 years. So the answer is no, but we hope it's coming.
Okay. Thanks. And thank you for saying that for me. Appreciate it. We've got someone who's has got a personal case history here, saying that they use a penile clip with very good success, and it does exactly the same as the atom, but at the other end of the urethra. Either way, you have to release the built-up urine, but $100 compared to $30,000 for the atom or sling. And they think that GP should suggest this is a non-invasive and cheap option. What do you think about that, Giovanni?
Yeah, look, I have quite a few men that come to see me using, we call it a penile clamp. I think one of the brands is the Wisner clamp. Look, it does stop the urine leaking, but a lot of men actually want the independence of not becoming reliant on a device like that. So I've had a couple that have chosen to use it long term, but most men, I find, they just want to get back to, some kind of new normal.
Yeah, okay. And you mentioned that there was some issues with cycling and the cycle seats with the AIMS device. Can using different types of seats overcome those issues, or not really?
So I'm not a cyclist, but I have a few patients who are, and you can get seats sort of have it like a donut shape, a bit of a cutout in the middle, that can help. And I do tell men to try and have a break every hour. So rather than, no longer than 1 hour in the saddle, having a break. I don't think it's a contraindication. So having an atom sling and being a cyclist, I don't think it excludes it. They just need to be aware it can be an issue.
Okay. There was a question for you, Peter. I know you did reply to it, but I thought it would be good to have it live. But what's the best way to connect our patients with the Prostate Cancer Foundation?
Probably the easiest way is by email, info@prostate.org.nz, or they can contact us on the phone on 0800 477 678. So that's free phone from anywhere in the country. It's 0800 477 678, or indeed just go to the website, which is prostate.org.nz.
Okay.
If I can also follow up just on Giovanni's comments on ACC. If at first you don't succeed, you can try again. If your application is declined, you can apply for a review, but that has to happen within 3 months. We are also, John, getting anecdotal reports of patients applying for ACC support with erectile dysfunction and being successful. Conversely, we're also getting reports of patients that are putting in applications for erectile dysfunction. They're being unsuccessful, they're applying to review, and then they're being offered incentives to withdraw their application for a review. So it's very grey on this. This is an area that we're actively looking at as a charity. Keep an eye on the website. We'll have a fact sheet up for men on prostate cancer post-treatment and ACC. And we'd also be very interested in hearing from any men who have applied, had their application refused, and are looking for assistance with the review of their application.
Thank you very much. That's great. We've got a question here about contraindications for erectile dysfunction prostheses. Is there anything that would contraindicate someone having these, like age or medical conditions or anything like that? It's
generally around fitness for surgery. Sometimes there may be some issues about reliability. I mean, occasionally you get people with some psychological issues that may not be well suited to that form of treatment, but generally it's available for most people. It's generally if they've got some significant medical issues that would preclude them from having a 2-hour anesthetic, or if there was some sort of concern that would put them at increased risk of some sort of complication afterwards. So bleeding disorder or whatever, but sometimes that can be managed.
I'm going to just add to that to say that, infection is the enemy for these prostheses, and poorly controlled diabetics would be someone I'd be concerned about.
I don't know about you, Giovanni, but that's a good point. I tend to want them to have an HbA1c of less than 60. Otherwise, I'll get them off to see a diabetic nurse or a diabetologist to see if they can get them down. And most of them can, but yeah, infection you really want to avoid. But most of them can get adequate diabetic control.
Great, thank you. And John, you replied to a question on here, but I thought it was quite an interesting one, because given that both of your talks are speaking about this, can the surgical solutions for erectile dysfunction and urinary incontinence that have buttons in the scrotum control them to be used together?
Yes, you can do a combined procedure. And you just put the pump's in a slightly different place. Normally, the penile prosthesis goes between the testes, and the pump for the artificial urinary sphincter goes just to the right side of the right testes, or on the left-hand side, depending on where the person wants to activate it. So you can put them in at the same time. Yes, you definitely can.
Very important not to get them mixed up, obviously. They're quite different. The pump on the penile prosthesis is quite large. It's sort of about the size of your thumb, and the pump on the artificial sphincter is more like the size of your little finger. So it's quite obvious which one's which.
And is there any impact on fertility with you using these devices?
The biggest impact on fertility is having your prostate removed, basically. So you'll be infertile after that. If you're having a penile prosthesis for non-prostate cancer reasons, it shouldn't affect your fertility.
Okay, awesome. And just going back on the penile clamp that we talked about, not penile clamp, urethral clamp, sorry, that we spoke about earlier, does the clamp have a retrograde effect on the sphincter?
Yes, I saw that question. I'm not entirely sure I know what it means, actually. Do you know what they might be getting at there, John?
No, I suppose, does it weaken it in any way? I'm not really sure, but the sphincter is weak anyway. I don't think it has any effect on it. Do you, Giovanni?
No,
essentially
it
you're
doesn't
using
worsen the problem, if that's what they mean.
Yeah, I think that may be what they're suggesting.
Okay. And just a handy hint would be requested here. So for those with erectile dysfunction who were successful with getting ACC, what did they write on the claim?
Yes, coming back to a point that John made, I believe that it is very important that the IIEF is rated on the patient before surgery. So their erectile function before surgery is graded. Also, I have heard, and again anecdotally, that it's important that it's noted, it's on the notes that the surgeon was attempting a nerve sparing procedure. Those are the two bits that I can say, but with the proviso that every claim is different, and also every claims assessor is different. So yeah, it's a really, as Giovanni says, it's a very grey area, and it's a hard one, and that's why we're putting some effort into it at the charity.
Well done.
Yeah, thank you very much. Well, I think that is all we have time for tonight. We have come to the end of our time, so I do apologise that we didn't get to the case studies, John. Maybe next time. So I just really appreciate you all coming to present tonight. So thank you, Giovanni, Peter, and John, for coming in tonight. And thank you so much to everyone out there who's joined us tonight. So have a lovely night, everyone, and stay safe out there.
Thanks very much.
Thank you very much.